Welcome to the Deep Dives, where we take sprawling, complex topics and boil them down to the nuggets you really need to know. Think of it as your shortcut to getting seriously smart on subjects that matter.
And today, we're plunging into a fascinating initiative called ProCANcer-I. This project, supported by the AI for HI Horizon Europe call, is tackling a really important challenge. How can we improve the way we understand, diagnose, and manage prostate cancer?
Exactly. We've got a wealth of information here, findings from their research, details about the studies they've conducted, and even, insights into the artificial intelligence they're developing. Our goal today is to make sense of ProCANcer-I, what they're doing, how they're doing it, the results they're seeing, and crucially, what all of this could mean for the individuals affected by prostate cancer, their families, and the healthcare systems to look after them.
Right.
We're all about clarity, so we'll try and keep the technical talk to a minimum.
Right. At its heart, ProCANcer-I is about bringing together the world of medical imaging, primarily MRI scans, and the power of artificial intelligence. The big aim is to deliver more precise and personalized care for prostate cancer at every stage, from when it's first suspected right through to ongoing management.
Okay, let's unpack this. One of the really interesting things ProCANcer-I has been doing is creating a whole set of AI tools. These aren't just general programs. They're designed for very specific jobs, yeah.
That's right. They've built AI models that can do something called segmentation. Think of it like drawing a precise digital outline around any suspicious areas or lesions they see on the MRI images.
Okay, like highlighting the spots to look at.
Exactly. Then there are classification models, which help doctors understand how aggressive a potential cancer might be. They also have detection models designed to spot cancer in the first place, and even tools that can automatically assess how good the quality of the MRI images is.
Image quality seems super important. I came across something called the PIQOL study. What's the story there?
Yes, PIQOL-OLA. Well, the study recognized that if you want to accurately find potentially serious prostate cancer using MRI, you absolutely need good quality images to begin with. As simple as that.
Makes sense. Garbage in, garbage out, really.
Pretty much. But having experts manually review all these images for quality takes up a lot of valuable time. So the idea behind PIQOLA was to develop an AI tool that could automatically score the quality of an MRI scan. This tool looks for things like blurry areas or ghosting effects caused by movement during the scan, issues that can make it harder to see what's really going on.
Okay, right. If the picture isn't clear, it's tough for anyone, human or AI, to find problems. Now, creating these AI models must involve a huge amount of information, right? Data.
Absolutely. For AI to learn effectively, especially using a method called fully supervised learning, where you basically show the AI lots of examples and tell it exactly what it's looking at, you need tons of data that has been carefully labeled by experts.
Labeled? You mean like someone pointing out this is a tumor, this isn't?
Precisely. These labels tell the AI what's a tumor, what's healthy tissue, and so on. However, getting all those labels can take a very, very long time and cost a lot of money, especially when you're dealing with the sheer number of MRI images. I mean, some of their models were trained on over 1 million individual slices.
Wow, over 1 million. Labeling all that sounds like a massive, massive task. So how do they handle that?
Well, they explored a technique called self-supervised learning. Now, this is a bit more complex for the computer, but the big advantage is that it doesn't need all those detailed human-generated labels. Instead, it allows the AI to find patterns in the data on its own. Think of it like a child learning to recognize faces just by seeing lots of faces, without someone having to point out every nose and eye every single time.
Okay. So it's more independent learning.
Right. This is really useful when you have huge amounts of data. They also use a specific type of AI tool called CatBoost, which is clever because it can even take into account the technical description of the different MRI scans used in the training data.
Okay, so they're building these really smart AI assistants. What kind of results are they seeing with the segmentation models, the ones that draw those outlines around potential problems?
The models that looked at specific types of MRI scans, called mpMRI, and were trained using data from different research centers, they were very good at spotting aggressive lesions. They had a recall of around 90%.
90% recall. So in simple terms, that means the AI was able to find almost all of the actual aggressive cancers that were present.
Exactly. It found most of what it was supposed to find.
That sounds incredibly promising, but I think I also saw a mention of a potential downside. A trade-off.
Yes, there's a balancing act involved, While it's great that the AI is very sensitive and doesn't miss many aggressive cancers, sometimes it might also highlight things that aren't actually aggressive or even cancerous at all.
So false positives.
Right, and this could lead to more biopsies being recommended, some of which might turn out in the end to be unnecessary.
Ah, so they're aiming for accuracy without being too cautious and potentially causing extra worry or procedures. That's the goal.
Exactly. But what's really encouraging is that their combined system, which likely uses a mix of different AI tools and analysis methods, was actually able to reduce the number of potentially unnecessary biopsies by about 20%.
20% reduction.
Yeah, and without missing many of the important lesions, that's a significant step forward for patients potentially avoiding an invasive procedure.
That definitely sounds like a real benefit. Were there other things that affected how well these outlining AI models worked?
Yes, a couple of things. The size of the suspicious area mattered. Bigger lesions were generally easier to segment accurately. Also, it made a difference whether the initial outline that was used to teach the AI was created by another AI or by a human radiologist.
Interesting. So the source of the training data matters too.
It does. This tells us that we still need to keep refining both the AI itself and the way we provide it with examples to learn from. It's an ongoing process.
Okay. Moving on to actually finding the cancer, I read that the AI could predict how aggressive a cancer might be just by looking at those specific mpMRI scans, without even needing those outlines or knowing exactly where the lesions were. That sounds pretty amazing, almost like magic.
It is quite remarkable, isn't it? They achieved a level of accuracy indicated by something called an AUC of 0.73.
AUC, what does that mean in practice?
Okay, think of AUC as a measure of how well the AI can distinguish between two groups in this case, patients with aggressive cancer and those without. A score of 1 is perfect, zero point 0.5 is just guessing. So 0.73 suggests the AI is doing a reasonably good job, definitely better than just chance. This implies that AI can detect subtle patterns in the MRI data that might be linked to aggressiveness, even if humans can't easily see them.
But I also noticed that the type of MRI scanner used and whether they used a special device called an endorectal coil made a difference. Why is that?
Ugh, that's a really crucial observation. The AI models performed better. Their AUC score improved by about 0.05, which isn't trivial when they were tested on MRI scans that were taken using similar equipment and methods as the scans they were trained on.
Right.
This really highlights how important it is to train these AI tools using a wide variety of data. The data needs to reflect the different types of scanners and procedures used in real hospitals, otherwise the AI might not work as well everywhere.
So you can't just train an AI on one specific type of MRI and expect it to work perfectly everywhere. It needs diversity.
Precisely. Generalizability is key. Interestingly, they also found that adding other information about the patient, like their age, their PSA level, that common blood test for prostate issues, and their initial PI-RASS score.
Which is the radiologist's score, right?
Yes, the standard way radiologists rate the likelihood of cancer on an MRI. Adding all that clinical data didn't actually make the AI models any better at predicting aggressiveness in this specific case.
That's unexpected. You'd assume that combining clinical information with the scans would make the AI even smarter. More data equals better results, usually.
It does seem counterintuitive, but it perhaps underscores the complexity of this disease and the potential of AI to extract really rich information directly from the images themselves in ways that traditional clinical factors alone might not fully capture. The image holds a lot of secrets, it seems.
Now, what about figuring out how aggressive a cancer is? I saw some mention of how many patient examples you might need to teach and test those AI models. It sounded like a lot.
Yes, those numbers really highlight how much data is often needed to build reliable AI in medicine. Depending on how accurate you want the AI to be and how complex the task is, you might need anywhere from, say, a few hundred to several thousand patient cases just to train the model properly.
Just for training.
Just for training. Then you need a completely separate set of data to test it and make sure it works well on new cases it hasn't seen before. Validation is critical.
And this idea of a radiomics pipeline, what's that all about? It sounds very technical.
Radiomics is a field that involves taking medical images, like MRIs, and extracting a huge number of very detailed, measurable features from them. We're talking about things like the shape, the texture, the intensity patterns of different areas within the image.
So, like breaking down the image into thousands of tiny data points.
That's a good way to think about it, yeah. The pipeline is the entire process, extracting all those features, selecting the most important ones, and then using those features to build AI models that can predict things like cancer aggressiveness or how well a patient might respond to treatment.
Okay. And these different ways of checking if the models are working well, internal, external, temporal validation, why are those important? You mentioned validation.
Validation is absolutely key to making sure these AI tools are reliable and, frankly, safe to use. Internal validation is like checking if the model works well on a different part of the same dataset it was trained on. It's a first step. External validation is much more rigorous. It's like giving the model a completely new test using data from a different hospital or a different group of patients it has never encountered before. That really tests its robustness.
And temporal.
Temporal validation looks at whether the model continues to work well over time because imaging techniques might evolve or the types of patients might change slightly. All these checks are essential to ensure the AI will actually be useful and accurate in the real world, not just in the lab. Generalizability again.
I also saw something about a whole gland radiomic signature using specific MRI scans and these fossil-wise radiomic maps. That sounds pretty advanced, even more than the pipeline.
It is quite cutting-edge stuff, yeah. The idea here is to look at the entire prostate gland in detail, not just focusing on individual suspicious areas that a radiologist might point out. By analyzing all those tiny data points, the voxels, which are like 3D pixels across the whole gland in those specific MRI sequences, T2, ADC, and high B-value DWI, they can create a kind of unique fingerprint or signature for each patient's prostate. The voxel-wise maps give a very detailed, almost pixel-by-pixel view of these radiomic features across the gland.
Okay, a fingerprint of the whole gland. And how might this actually be used in a real doctor's office? They gave a couple of examples, right? A 76-year-old and a 73-year-old.
Those examples help to show the potential clinical application. So imagine a 76-year-old man comes in with a slightly elevated PSA level. His standard MRI shows a potentially concerning area. Now, an AI tool that can automatically outline the entire prostate gland, combined with another AI model looking at the whole gland's radiomic signature from those specific MRI types we mentioned, could provide doctors with much more detailed information.
Information about what exactly?
About the likelihood and the potential aggressiveness of any cancer that might be present, even looking beyond that one suspicious spot. This could then help the clinical team decide if a biopsy is really needed and, importantly if so, how to best target it to get the most accurate sample. The same principle would apply to the 73-year-old example with similar findings.
So it's about giving doctors more, maybe better information to make better, more informed decisions for their patients. That makes sense. But I also noticed a really important point they made. Just because an AI works well in a research study doesn't automatically mean it will work perfectly in a real busy hospital.
That's a crucial reality check. AI models can perform really, really well on the carefully selected and prepared data they're trained and tested on in a research environment. It's often quite controlled. However, when you introduce them into a busy clinical setting with different types of patients, maybe older MRI scanners alongside newer ones, slightly different ways of doing things day to day, their performance can sometimes drop. It's called the generalization gap.
So that external validation you mentioned is really critical then.
Absolutely essential. That's why it's so important to thoroughly test and validate these tools using data from many different sources, different countries, different hospitals, to ensure they're truly reliable before widespread use.
And ultimately, the goal isn't just to have a clever piece of technology, right? It's about making things better for the people affected by prostate cancer, patients.
Absolutely. That's the bottom line. The real success of these AI models won't be measured by their AUC scores alone, but by whether they lead to tangibly better patient outcomes, improve the quality of care, reduce unnecessary procedures, and effectively solve the real-world challenges that doctors face every day in managing this disease.
This brings us to the idea of fair AI and these future AI guiding principles. What's the thinking behind that? It sounds important.
It's incredibly important. As AI becomes more integrated into healthcare, it's absolutely vital to make sure it's used responsibly, ethically, and fairly. The future AI principles, that's fairness, universality, traceability, usability, robustness, and explainability, provide a kind of roadmap for doing this.
Okay, can you break those down quickly? Fairness.
Fairness means the AI should work equally well for all types of patients, regardless of their race, ethnicity, age, or other characteristics. We don't want biases creeping in.
Universality.
That suggests using existing standards and making sure different AI systems can work together, interoperability.
Traceability.
That emphasizes the need to keep track of how the AI was developed, what data it was trained on, and how it makes its decisions. Documenting everything.
Usability.
Means the tools should be easy for doctors and other healthcare professionals to actually use in their workflow, not cumbersome,
Robustness.
ensures the AI is reliable and can handle different kinds of data, even maybe slightly lower quality images, without completely failing.
And explainability. That sounds particularly critical in medicine.
It really is. Doctors need to understand why an AI is suggesting something, why it's flagging a certain area or predicting a certain outcome. It's not a black box.
Why is that so important?
Well, it builds trust. It allows clinicians to combine the AI's insights with their own medical knowledge, their experience, their judgment about the individual patient. They need to remain in control.
I also saw a section on radiologic histopathologic correlation. That sounds like they're trying to connect what they see on the MRI scans with what they find when they look at the actual tissue samples under a microscope after surgery.
That's precisely the goal. While the features that the AI detects in the MRI images, the radiomic features, can be very powerful for prediction, they can sometimes be a bit abstract, just numbers and patterns. This part of the project aims to understand the biological basis of these features. They do this by comparing the MRI findings very carefully with the detailed information from tissue samples taken during surgery to remove the radical prostatectomy specimens.
How do they compare them accurately? The MRI is an image. The tissue is, well, tissue.
They're using a sophisticated computer process, basically of software, to precisely align the 3D MRI images with the corresponding 2D histology slides made from the tissue samples. It's complex image registration.
And they've achieved a good level of alignment between the images and the tissue, it seems.
Yes, they reported a good average dice coefficient, which is essentially a mathematical measure of how well the computer's alignment matches up the structures in the two types of images. This detailed comparison can help us understand what the AI is actually seeing in the MRI in terms of the real cancer cells, the glands, the surrounding tissue architecture,
Right.
linking the image patterns to biology.
So they're not just looking at patterns in the images. They're trying to figure out what those patterns mean at a biological level. That's really interesting. It sounds like while AI in prostate cancer imaging is making huge strides, there's still a significant amount of work needed to make it a routine part of how doctors care for patients day to day.
Absolutely. That's a key takeaway. The project highlights the need for collaboration between many different experts: radiologists, pathologists, oncologists, AI specialists, data scientists, engineers, the whole team. And crucially, investing in good quality, diverse data, the skilled people who can work with it, and the necessary technology infrastructure are all essential to make this move from research findings to real-world clinical practice successful. It takes time and resources.
Now let's circle back to the PIQAL study for a moment. We talked about its aim to create an AI tool for assessing MRI quality. What did they actually discover about the quality of MRI scans in the database they used, ProstateNet?
Right, so the PIQAL study involved a large set of 900 MRI exams. These were reviewed by radiologists, both experienced and less experienced readers. Overall, they found that about 82% of the images were considered to be of good diagnostic quality.
And the rest?
Around 18% were rated as low quality, meaning they might not be good enough for reliable diagnosis. This gives us a valuable snapshot of the kind of image quality variability they're working with in real-world data.
And which specific aspects of the MRI scans seem to have the biggest influence on whether it was deemed good or low quality?
Their analysis showed that several things were particularly important. For the standard T2-weighted images, which show the anatomy well, being able to clearly see the different structures within the prostate, like the zonal anatomy, was a major factor. For the diffusion-weighted images, or DWI, which are very important for detecting cancer, several things mattered. The absence of significant distortions or blurry areas, having good contrast and signal strength, making sure the ADC maps, which are calculated from DWI, had appropriate contrast, and importantly, that the DWI images lined up well anatomically with the T2 images.
So things like how clearly you can see the prostate gland and whether there are distracting artifacts or misalignments are key indicators of image quality. Were there specific types of artifacts that were most likely to lower the quality?
Yes, they identified a few common culprits. For the T2 images, it was often signal graininess, blurring, and motion or ghosting artifacts. For the DWI images, the main problems were blurring, motion, or ghosting again, and also geometric distortions, where the shape of the prostate might look a bit warped.
And did technical factors like resolution matter?
Interestingly, yes. They found that how fine the image detail was, pixel resolution, and the thickness of the slices in the MRI had a statistically significant impact on the quality of the DWI scans, but not always on the T2-weighted images. Little technical details can make a difference.
That's really useful information for the technologists performing these MRI scans, isn't it? It highlights areas where they can focus to get the best possible images for diagnosis.
Exactly. Quality control is vital.
And what's the latest on developing the AI tool itself, the one that can automatically score this quality? How's that progressing?
Well, there are actually 6 different research teams involved in this specific task within the ProCANCER's project. They're exploring various AI methods, including deep learning and radiomics approaches. Initial results from teams like the Champalimaud Foundation in Portugal and FPO Candiolo in Italy are showing promising accuracy in predicting whether an MRI study is of sufficient quality for diagnosis.
Promising how?
Any numbers. Yeah. For example, Champalimaud reported an AUC, that accuracy measure again, of 0.85 with one of their AI models comparing deep learning versus radiomics. FPO Candiolo achieved an accuracy of around 78% with their deep learning approach, so they're definitely making headway.
Those sound like encouraging first steps. What are the next plans for the PIQL study? Where do they go from here?
They're planning to organize a kind of open competition, often called a challenge, where different AI tools from various teams can be tested head-to-head on a common set of MRI data to see which performs best. They also aim to combine these objective AI quality assessments with the more subjective quality ratings from radiologists, like the PIRA scores, into a single comprehensive tool for evaluating MRI quality. The goal is a really robust way to ensure the MRI data being used for diagnosis or further AI analysis is high quality.
It sounds like they're really working hard to build a dependable way to ensure the foundation of their AI work, the MRI images themselves, is as good as it can be. Very
It
systematic.
has to be.
Now, the project also involved testing how well these AI detection models worked in a clinical setting, right?
Yeah.
With actual radiologists. What was the main goal of that specific validation?
Yes, use case 1, I believe. The main goal of that part of the project was to directly compare how well radiologists can find prostate cancer on MRI scans when they have the assistance of AI-generated probability maps highlighting suspicious areas versus when they are looking at the scans on their own, unassisted.
So AI versus no AI, head-to-head with readers.
Essentially, yes. They also had several other secondary goals, like seeing if the AI help made a bigger difference for less experienced radiologists compared to those with more years under their belt. And also looking at how it affected the ability to detect different grades of cancer, particularly the more aggressive ones.
And how did they go about conducting this study? Who participated?
They used a set of MRI exams that hadn't been seen before by the participating radiologists. These were collected prospectively over several months and represented different MRI scanner manufacturers, mostly the higher-strength 3T scanners. The cases were chosen carefully to include a mix of different sizes of potentially cancerous areas, and overall, about half of them actually had biopsy-proven prostate cancer.
And the readers?
They had 20 radiologists from 10 different hospitals across Europe take part. Half were classified as experienced in reading prostate MRIs, and half were less experienced.
How did the reading work?
Each radiologist looked at the same set of MRI cases twice, but with about a 6-week gap in between to reduce the chance they'd just remember the case from the first time. The first time, they read the images without any AI assistance, just the scans. The second time, they had AI probability maps from 2 different AI models developed within ProCANCER to help them interpret the images.
2 different AI models. Why 2?
Good question. It allows comparison not just of human versus AI-assisted human, but also potentially different AI approaches.
Okay. And how do they know for sure whether cancer was actually present in each case? What was the ground truth?
They used a reference standard. This was based on carefully matching the locations of any suspicious areas the radiologists identified on the MRI with the findings from biopsies that were performed. These biopsy results were confirmed by pathologists looking at the tissue under a microscope. So if the locations matched and the pathology confirmed cancer, it was considered a correct detection, a true positive. If a radiologist thought they saw cancer in a spot where the biopsy was negative, that would be a false positive, and so on. It's quite a rigorous process.
Okay, so what did they find? Let's start with the radiologists reading the scans without any AI help. How accurate were they on their own?
On average, without AI assistance, the radiologists correctly identified about 57.8% of the cancers that were actually present. That's the sensitivity. And they correctly identified about 68.1% of the cases that did not have cancer. That's the specificity.
So roughly, they found a bit over half the cancers and correctly ruled out cancer in about 2/3 of the negative cases.
That's a fair summary of the baseline performance. There were some slight differences between the more and less experienced radiologists, as you might expect, but these overall numbers give us a starting point to see if AI help made a difference. They also looked specifically at how well the radiologists could distinguish between cases with any grade of cancer versus no cancer, and also, importantly, between lower grade cancers, which might not need immediate treatment, and the higher grade, more aggressive cancers.
Right. And how did the AI models perform when they were used on their own, standalone, without the radiologists?
As we touched on, the two AI models presented their findings slightly differently. AI model #1 used a probability threshold, so it only highlighted areas where it was pretty confident cancer might be present. It had a sensitivity of 55% and a specificity of 61.3%.
So similar sensitivity to the unaided radiologists, slightly lower specificity.
Correct. The other model, AI model #2, was designed to be more inclusive. It showed all the areas it thought might potentially be suspicious, even if it wasn't as highly confident about every single one. This resulted in a higher sensitivity of 70%, meaning it found more of the actual cancers, but it had the same specificity of 61.3%. So it also flagged more things that turned out not to be cancer, more false positives.
Okay, so AI model #2 was better at not missing cancer, but also potentially more likely to raise false alarms if used alone. Now, the key question, what happened when the radiologists used these AI models as an aid?
Right, this is where things get really interesting. They found that when radiologists used AI model #2, the more sensitive one, their ability to correctly identify cases without cancer, their specificity, significantly improved compared to when they rule out cancer more accurately.
Yes, for detecting any grade of cancer.
Yes.
And even more striking when it came to the crucial task of distinguishing between lower grade or no cancer and the higher grade clinically significant cancers.
Using AI model #2 actually led to statistically significant improvements in both how well they found the higher grade cancers, sensitivity went up, and how well they correctly identified the lower grade or no cancer cases, specificity also went up. And this improvement was seen across the board for both the experienced and less experienced radiologists.
Wow. Okay, so that specific AI assistant seemed to make them better at finding the dangerous cancers and better at correctly identifying the less worrying cases. That's a really important finding.
It really is. It suggests that this type of AI assistance, the one that highlights a broader range of potential issues, can help radiologists be more accurate overall in their assessments, particularly when it comes to identifying the more serious higher-grade cancers that definitely need attention.
Did they look at how detection varied depending on the initial MRI appearance score, the PIRS score, or the confirmed aggressiveness, the ISUP grade?
Yes, they broke down the sensitivities by PIRS score and ISUP grade for both unassisted and AI-assisted reading with both models. As you'd expect, detection rates generally increased with higher PI-RED scores and higher ISUP grades. The AI assistant showed varying effects across these subgroups, which provides really granular data for understanding where the AI helps most.
And they even included a specific example of a real patient case, didn't they?
Yes, they did. Case PCA 190-something. It had a PI-RAD score of 4 and turned out to be a highly aggressive ISU grade 5 cancer, showing the lesion location, the biopsy method. It just helps to make the abstract data feel more concrete, illustrating how these tools might be applied in a real-world scenario.
So to sum up the clinical testing of these detection models, it seems that having AI model #2 as an assistant significantly helped radiologists. It improved their specificity for detecting any cancer and improved both sensitivity and specificity for differentiating the low grade from the higher grade, more dangerous cancers.
That's a good summary of the key positive findings. They also validated their initial hypothesis of achieving at least a 10% sensitivity increase for detecting those higher grade cancers with AI assistance.
And what about reading time? Did the AI make things faster or slower?
Faster. They found that the time it took radiologists to read and interpret the MRI scans was significantly reduced by about 12% to 23% when they were using AI assistance.
That's quite a saving.
It really is. In busy radiology departments, that kind of efficiency gain could have significant benefits for workflow and patient throughput.
However, the researchers were careful to point out some limitations of this validation study, too.
Yes, and that's good scientific practice. They mentioned potential challenges in precisely matching the areas identified by the radiologists on the MRI with the exact locations sampled by the biopsy needle. That registration isn't always perfect. They also noted that their study population had a slightly higher proportion of lower-grade cancers, ISU grade group 1, than what is typically seen in everyday clinical practice in some centers. This might have influenced the overall findings slightly, perhaps making the specificity gains look more pronounced than they might be in a population with more high-grade disease.
Okay. So while the results are definitely encouraging, especially for model #2, it sounds like more research is needed in maybe even more diverse clinical settings to fully confirm and understand these findings.
Exactly. Further analysis, perhaps looking closely at the impact of image quality on these results, is likely warranted, but it's a very positive step.
Finally, they also did some work to check how well the AI models could segment or outline the prostate gland itself, not just the lesions, right? How did that validation go?
Yes, that was another part of the project. The main aim there was to evaluate how accurately the different AI segmentation algorithms developed within ProCancer-I could automatically draw the boundaries of the entire prostate gland and also specific zones within the prostate, like the peripheral zone and the central transitional zone.
Why is segmenting the whole gland important?
It's useful for various things, like calculating prostate volume accurately, which can influence treatment decisions, and also for providing context for where lesions are located. Plus, it's a step in that whole gland radiomics analysis we talked about. A secondary aim was also to get a sense of how much agreement there is between different human experts when they manually outline the prostate on MRI scans, because even humans don't always agree perfectly.
Right, establishing a baseline for human variability. And what did that part of the study involve?
They used 160 MRI exams from the same prospective dataset as the detection model study, again ensuring a good mix of MRI scanner types and vendors. 8 experienced radiologists from different hospitals across Europe took part in the outlining.
How was the work divided?
Most of the MRI scans were outlined or segmented by one radiologist each. But for 20 of the scans, they had 3 different radiologists outline the same scan independently. This allows them to measure the inter-rater variability. How much do expert outlines differ?
And what's the current status of that work? Have they got results yet?
As of the time of the report we're drawing from, most of the radiologists had completed a significant number of these prostate zone segmentations. The first batch of about 110 segmented cases had been released internally for the AI model developers to start testing their algorithms against these human expert outlines. However, they were still waiting for a couple more radiologists to complete their segmentations for that inter-reader variability part of the study. So that specific analysis was still underway. The models were being validated, but the human comparison wasn't fully complete yet.
Okay, so still ongoing work there. It really sounds like ProCancer-I is a incredibly comprehensive project, doesn't it? Tackling so many different aspects of prostate cancer diagnosis and assessment using the power of AI.
It really is. From image quality assessment to lesion detection, classification, segmentation, biological validation, it's covering a lot of ground.
So bringing it all together then, thinking about everything we've discussed, what do you see as the biggest potential impact of this kind of technology?
Right.
The ProCancer tools and others like them for patients, for their caregivers, and for the healthcare systems as a whole.
Well, the potential impact is truly significant, I think. For patients, the hope is clearly more accurate diagnoses. This could mean catching aggressive cancers earlier, or just as importantly, avoiding unnecessary biopsies and the anxiety that comes with them if the AI can confidently help rule out significant disease, ultimately leading to more personalized treatment approaches and better outcomes.
And for caregivers, family members,
For caregivers, having more confidence in the diagnostic process, feeling like the best tools are being used, could really help alleviate some of the stress and uncertainty that comes with a potential cancer diagnosis for a loved one.
makes sense. And for the bigger picture, the healthcare systems.
For healthcare systems, there are several potential benefits. We saw the potential for faster reading times, leading to more efficient workflows in radiology, better allocation of resources, maybe focusing biopsies on the highest risk patients. And if AI helps detect aggressive cancers earlier and more reliably, that could lead to improved public health outcomes and potentially reduced long-term healthcare costs associated with treating advanced disease.
It's clear that this is a complex and rapidly advancing field. This deep dive has given us a really insightful look at the progress being made by projects like ProCancer-I, but also highlighted the ongoing work needed to translate this exciting AI research into real, tangible benefits for people affected by prostate cancer.
Absolutely. While we've seen some very promising results with these AI models for detecting, outlining, assessing quality, and even hinting at biological underpinnings on MRI scans, it's just so crucial to continue to rigorously test and validate them in diverse, real-world clinical settings. That PIQ-all work on quality, the clinical validation studies, they're essential. And as we said, the ultimate measure of success won't just be technical metrics, but the positive difference these tools actually make in the lives of patients and the efficiency and effectiveness of our healthcare systems.
So as we see these rapid advancements in AI for medical imaging continue, a final thought maybe for our listeners. What do you think are some of the most important practical or ethical considerations that will need careful attention as these technologies become more and more a part of routine healthcare?
Hmm, that's a big question. Things like data privacy, ensuring equitable access so these tools don't widen health disparities, managing algorithmic bias, figuring out regulatory pathways, and maintaining that crucial human element, the doctor-patient relationship, in an increasingly technological landscape. Lots to think about.
Definitely food for thought. It's certainly something to keep in mind as projects like ProCancer continue to push the boundaries of what's possible. If you're interested in learning more, we encourage you to explore the ProCancer-I project and the wider world of AI in medicine. Thanks for joining us for this deep dive.